the good sense. It means we can actually do business. Thank you. And Rose, you don't have to get Robert out of his meeting.
Okay.
So
I
we'll
think
go
Ollie
ahead
was
and
working on that.
I am going.
Yeah.
Okay. I'm going to call to order the December 5th, 2023 OEBB meeting. We're meeting virtually, and we have a quorum. I have a couple things to do. First, to welcome you all. Thank you for being present. And we have two action items to start. The first is November 7th meeting minutes, and people can make comment, and we can have a motion to approve.
I move to approve.
Bonnie moves to approve. Is there a second?
Second, Susan.
Thank you, Sue. Okay, all in favor say aye.
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 All opposed say nay. It's unanimous. Thank you. The first order of business is the request for approval for a permanent rule. And April, you join us every once in a while and kind of confound us with legalese, but you're on. You confuse me. You might not confuse the others, but you always confuse me.
Sorry.
I don't.
Sorry about that.
No, it's my fault, not yours.
April Kelly with Pebble OEBB staff, and yeah, when you see my face occasionally on here, it's because I'm gonna ask you to take action on something. And in this case, you've actually already reviewed these back in October when I crashed your all's retreat. You gave me approval to go through the permanent rulemaking process and to take the Division 70, Section 75 rules, which are administration of our SB 551 program. I took those through the rulemaking process. I filed with the Secretary of State the notice. I sent the notice out, held a public rules hearing. We did have a few attendees, but we didn't have any official public comment on the rules. And I think part of that is because back when we held the Rules Advisory Committee, we really got the kind of the key stakeholders in the room and did some tweaks to the rules. But at any rate, back here asking approval to file these, what are currently proposed rules, but file them permanent with the Secretary of State's office.
Does anybody have any questions for April? If not, I'll accept a motion to approve the permanent rules.
So moved. This is Sue Ricky-Smith.
Bill Graup, second.
Thank you, Sue. Okay. Again, all in favor of approving the move to permanent rule status for what April has sent us. All in favor, say aye.
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 Any opposition? It passes unanimously. Thank you, April.
Thank you so much.
Okay, so we are now going on to our next item, which is the 21-22 trend rate guarantee, and a summary. We discussed this at the board meeting last month, and Margaret and Kirsten are going to give us a summary.
Hey, good afternoon, everyone. Kirsten, I guess I can go ahead and set the stage and dive in. Rose, if you could advance to the next slide, please. So as board members who were present at the November meeting may recall, we brought this agenda item forward to the board. Specifically, this relates to a trend rate guarantee that it was contained in OEBB's 2020, excuse me, during the 2021-2022 contract. And it was related to having carriers place 5% of administrative fees at risk for maintaining annual cost growth within the 3.4% limit. And so the way this guarantee works is for the 2021-2022 contract year, that's considered the measurement year. It looks at plan cost growth compared to the base year, which is the prior year, in this case 2020-2021. And if cost growth is in excess of 3.4% for the plan, there is a penalty applied. Now that penalty amount is 2.5% of administrative fees if the cost growth lands in a corridor of 3.4% to 4%. If the cost growth is for that measurement period is higher than 4%, the penalty is 5% of administrative fees. And so we've done the number crunching and the analysis to see where results panned out. And for both OEB carriers, cost growth came in excess of that 5% for the measurement year. You can see here on the slide that results in penalty amounts owed for both Kaiser and MODA. And so the decision before the board is related to how the board would like to move forward with settling this aspect of the 2021-2022 contract. We identified several options that were talked about at the November meeting that are available to the board to proceed with settlement. And those, if you can advance, I don't believe we have those on the next slide. Yeah, go ahead, Tom. Did you want to chime in?
Yeah, actually, we just have this summary. And so I'm going to take it from here. And so I think the board has two different decisions. The first decision, if it goes in one direction, we don't have to make a second decision. But the first decision is whether or not the board wants to waive this penalty or enforce it. And we had a bit of a conversation about this last time. For those of you who were on the board at this time, you never voted on this factor, this trend guarantee. It was discussed at the joint OEB-PEB innovation work group. And it was then carried on into contract. And this was, the idea is that costs are what's going to drive what we pay for our insurance. And of course, as I mentioned last time, the significant alteration to the way that this naturally should go was the previous year we had the pandemic and costs and utilization significantly dropped. So, and yet the measure is based on a year-to-year change. So let's say utilization dropped 5% and it rebound, and that rebound obviously pushed beyond the 3.4%. So it was my recommendation in November that we do not apply the penalty, because for them the carriers to have reached this, they would have needed to essentially deny care. There was, however, people who felt we need the money, so let's just go ahead and do it. So, and both of those, that's not right or wrong. That's just how one approaches this. The first thing I would like to have is a motion to approve the penalty, and then we will vote whether or not to put the penalty in place. So, people who think that the penalty is inappropriate would vote no. Those who think the penalty is appropriate to apply to the plans would vote yes. So may I have a motion to approve the assessment of the penalty?
I have a comment, not a motion.
Let's get a motion on the table first, and then we'll have comments. You'll be able to do.
The problem, my comment is why making this motion is not a good idea, right?
The board. I would ask the board to. I have a strategy in terms of working through this bill. Would you please go along with me?
There's an issue with that strategy, but I'll roll with what you're saying. I just have a big problem with your strategy.
Please.
I move. This is Enrique. I move to improve the trend guarantee discussion for the 2023-2024 year.
Bonnie, second.
Motion.
Yeah.
What was the motion? I couldn't hear it.
The motion was unclear, Enrique.
You're breaking up, Tom.
I'm asking for a motion to approve the application of the penalty that's included in the trend guarantee. It's a simple
move
request.
To approve.
Thank you.
I'll second to approve.
Penalty.
Okay, Bill, please.
Oh, sorry. So we have a motion and a second.
Yes.
Is that right?
Yes.
Okay. My comment was I didn't feel the motion was could be decided upon or made if we don't really know what the options are. If we approve the penalty.
That's an opinion. I think we have to decide whether or not we should approve the penalty or not. The options are something that once you've said yes, the penalty should be applied, or no, the penalty shouldn't be applied. That's the first issue. That's my opinion.
Okay. And the motion was to approve the penalty. That's what I heard. Is that correct?
So, yes.
Okay.
So a yes would be yes, the penalty is applied. No, the penalty is essentially waived. Any comment, any discussion on the motion? Otherwise, this one I'm going to do a roll call vote. Now, again, please remember, a vote yes is to apply the penalty. A vote no is to waive. Susan, you have a question.
Thank you, Tom. Can you explain to us what would happen if the penalty was waived?
What would happen is those dollars that you see in that bottom right, the 2.4 would not go anywhere. The plans would keep that money. Those were administrative fees that were included in the contract. The contract had in it a penalty if something happened, and that was a trend guarantee that was greater than 3.4%. And if it went above 4%, it would be the full penalty. This is the full penalty. Does that answer your question, Susan?
Thank you, Tom. I do understand that part, but does it just go away?
It's money that was included in their contract. It was money that was essentially earned, but that was money that was put at risk. So we have performance guarantees that are financial, administrative, and clinical. It's like if they didn't meet the clinical quality, there's a penalty that's available. This is a financial this is a penalty related to whether or not they made the plans kept their increase in trend, which is the cost 1 year over the other, at below a certain level. So the money is essentially theirs, but this contract issue raises that they now owe OEB if we so choose. And we'll then talk about what happens with that money. But that money would then flow to the money that you see here would flow to OEB.
So
So the way
likely
I
out.
understand is, Tom, if, go ahead, Susan, I'm sorry.
Thank you, Enrique. I was just going to say, so a yes vote then would likely then either take this money out of reserves or be assessed to our money.
This, if you vote yes, the Kaiser Permanente will will owe OEB 600,000 plus, and MODA will owe OEB 1.8 million. That's what happens.
Thank you.
It's their money now, but if we apply the penalty and follow what the contract says, that money will flow to OEB. Okay, so any other questions? Enrique, I didn't hear you. You're broke up. Any comments? Okay, so I'm going to go through a roll call vote. Once again, yes means the plans pay OEB this money. If you vote no, you're waiving the fee. Okay, Bonnie.
Yes.
Okay, Bill.
Yes.
Sue.
Sue Ricky or Sue Miller?
Oh, I'm sorry. I say Sue and then Susan, but Sue Ricky Smith. Sorry.
Yes.
Okay.
Yes.
Enrique.
Yes.
Michelle.
Yes.
And Susan.
Yes.
Okay. So of those voting, it is unanimous. What's the vote? How many votes do we need for it? Do I have to vote, Ali?
Yeah, you do, Tom.
Okay, and I'm voting no. Okay, so it's 6-1, and so now the plans are being told they need to they owe OEB this amount, there has been conversation with the plans that one of their options is to simply send this money forward, for them to essentially write a check, and Ali, it would go into the administrative fund. Is that correct?
It would go in the stabilization reserve.
Okay, to the stabilization reserve. The other option that both of the plans have agreed to is to take this money and essentially roll it into, essentially to subtract from their rate increases for 24-25. And we're sure that we're going to have a challenging renewal this year. That's now the next decision point, is to decide how we want to move forward with the with this $2.46 million, and which the plans owe. And I'm going to just open that up. Bill, you had thoughts about this before, and I'd love to hear your opinion.
So mine pretty straightforward. I would like the board to commit to using these fees directly back as buy down on the rates that are about to be presented in February and March for our consideration. That was not limited to, but a minimum of this amount for each Kaiser and MODA for buy down of the rates.
Okay, so in terms of, if you made that into a motion, it would be to essentially require Kaiser and MODA, to the amounts that you see in the bottom right, to essentially apply that money that they owe OEB to 2024, 2025 rates.
rate down at a minimum, so that at a
Okay,
minimum,
right,
this
right,
amount is used to buy down the rates of what's
Okay.
presented.
And is that a motion?
It can be.
I would love it. I'd love for it to be a motion.
Okay. I'd like to make a motion. Oh, hold on, I got a hand up. Before I
So
make
you
a motion,
go
I
ahead
have
and
to
make,
retract
go
it.
ahead and make your motion, and then we'll get to Ali.
Oh, because if he's going to correct me, I'm going to have to correct.
Oh.
We have to correct the motion.
Okay, Ali, you're
Right.
on.
Thanks. Sorry about that to jump in, but I'd say credit versus buy down would probably be
Okay.
Okay.
better. So it's not, part of that 3.4%,
So can I say
Got it.
credit in the rate
Thank you, Ali.
determination? Does that sound right?
Yeah.
Okay. So thanks for that. So I'll make a motion that the board approve that a credit in the amounts shown for both Kaiser and Moda for the trend guarantee fees be made to the rates being proposed for the next upcoming renewal year.
Do I have a second?
This is Siriki Smith. I'll second.
Thank you. Any comments on this, on the motion? My comment is it's the best alternative that I see. So I'm very supportive of this. Susan.
I'm very supportive of the concept of it, but I'm concerned about not seeing the rates first and then making the decision.
Okay. We won't see them for we won't see the preliminary. Kirsten, help me. Is it next month? Is it January that we see the preliminary, or will it be February that we see the preliminary rates?
They come in January after we've already had the January meeting, because
Okay.
it's first thing on the 2nd. So you'd see it in February for the first time.
Okay, so we won't see them till then. So there's the possibility of, okay, and Bill, you might be next.
Enrique was first before me.
Enrique, I see you come up. Fine. Enrique, you're next.
Yes, so the way I understand this motion is that if it's approved and implemented, we will be able to control the benefits and not have any cuts or any increases out of our sort of the guidelines that we have, right?
I think what it means is that we would not these funds, as I say, going into the rate stabilization, these would kind of guarantee being put into the rate formulation for next year. I'm not sure if that helped explain things. I'm going to have Kirsten save me in this from this situation and
let me put
explain
my hand
it.
down here. Right?
Yeah,
I'm put my hand down and put Kirsten up. Right.
yeah, you're on,
I'm
Kirsten.
wishing we had additional slides on this, because it can be so helpful to have a visual. So when we have this money available as a renewal credit, just to put things in context for people, if we think back to last renewal, we were in a situation where the Kaiser and Moda renewals were above 3.4%. And so we had a conversation around potential benefit cuts, RSR. We wound up spending about $2.5 million in RSR to buy down the rates to get our overall renewal at 3.4%. And we have money left over in RSR, and we're going to talk about that in the renewal primer. Really, what we're talking about in this conversation is having additional cushion available. So it's true, we don't know what the renewal increases are. We can guess. We saw how the Kaiser renewal was for PEB, and we're under Kaiser's renewal now for 2024. And we can anticipate with the tight labor market and high inflation rates we've been seeing that it might be a tougher Moda renewal. I just want to set the stage, though, put this money in context. So $2.5 million is about enough to buy, to reduce the renewal increase about 0.25%. So I just didn't want to set the expectation that this money could eliminate any sort of future conversation about other things we might need to do. But what it does do is it makes the conversation a little bit easier. If we had to take benefit cuts, it would be less benefit cuts. Of course, that's a last resort. If we needed to spend RSR, it would be less RSR if we add this money to be available.
Thank you. And Bill, you're on.
Okay, and I guess I'm kind of with my motion, because in the CL meetings, I know there's some added increases that we're planning on additional benefits to consider by this board, and some of them are small enough that this money will be quite helpful for that. And one of them, the dual, will come up in the future part of this meeting, but also some reproductive health. So those are kind of the numbers that I know are there. So that's why I make the motion to just go ahead, and the rates will be higher for that. So it'll help with that.
Enrique, did you want to go ahead and comment again? Did you get your issues addressed?
Thank you, Tom. So for what I understand, if this motion passes based on the motion that we voted on, we will able to we will able to avoid any further cuts to healthcare benefits, or
it will
so
help.
I'm supportive of that. Yeah.
Yeah, it will help. It won't eliminate. It will help. It's possible that we're still, let's say the rate increases proposed were 6%, and we have a 3.4 challenge. This would help a little bit. If the rate increases were at 3.8, it may solve it. But that's it. The perspective is the only thing that I would do to adjust to what you just said.
Awesome. Thank you.
It's definitely directionally correct. Yeah. Okay. Any other comments or questions? Because we do have a motion to vote on. Okay. So I'm going to do a roll call on this one also, and yes is asking is having plans move the money as outlined in the bottom right into as credits for the 24-25 rates. So I'm going to start with you, Bonnie.
Yes.
And Bill.
Yes.
Sue Ricky Smith.
Yes.
And Enrique.
Yes.
And Michelle.
Yes.
Susan Miller.
While I want this money to be applied to those rates, I still don't feel comfortable saying yes without knowing the rates first, so I will say no.
So do you say no? Okay. And I am going to vote yes. So the vote passes 6-1 approval. Okay, thank you. This was complicated. I appreciate you putting up with my with my approach. I wanted to try to be as clear as we could in terms of how we move forward with this. Bill, you have
just one quick comment that I'd like to just make a recommendation that that this board know a little louder or a little more things when there's these kind of guarantee and contract things. Just that we know it's going on at a minimum. That I know it was brought up before, but a little stronger. I would make that suggestion.
I am with you 100% on that.
Thank you. Thank you both.
We'll make sure we do it. Yeah. Okay. So we are now, Kirsten, we are now on to the renewal primer, and we're only 7 minutes over.
Perfect. Thanks, Tom. Hi, everybody. We're going to set the stage for the 2024-25 renewal. I'm sure I'll say the wrong year here at some point because we're also talking about 25-26 in some conversations. So just heading into the busy renewal season, and you'll get a little bit of a break in January while we do some work behind the scenes with your carrier partners, and then you'll begin to see things in February and March and make decisions in April. We just wanted to set the stage and do a little bit of a renewal kickoff headed into next year. Next slide, Emily. Hopefully you all have these committed to memory by now. I know that the Mercer team does, but we wanted to just refresh on the 2023-24 decisions that you guys made and how they related to your goals. And just briefly again, with the shift left goal that we talk a lot, which is really just a focus on wellness and preventing disease. Member education, which is helping OEB's members understand the full suite of benefits available to them and make good use of the benefits. Of course, we have the 3.4% cap, which we'll have the opportunity to talk about a lot today, especially during the GLP-1 conversation. And then we have a focus on providing high quality and efficient care, in parentheses, while always keeping the member first and watching that member experience. In terms of shift left, we had quite a few things. Kaiser had some additional care delivery options that they added around virtual care. MODA added the type 2 diabetes reversal solution, VERTA. Kaiser expanded colorectal cancer screening services that are considered preventive, which means they're offered at $0 cost share, and also expanded naturopathic benefits to out-of-area dependents. For member education to help our members, MODA improved translation services, both for virtual and in-person care. And we just changed the VSP benefit schedule. So benefits would be per plan year instead of every 12 months, which is off cycle for OEB. To help us meet the 3.4% cap, we discontinued the low value WebMD, implemented the Copay Max Plus program through MODA. The overall combined medical, vision, dental renewal was 3.4% in the end. We'll see some more detail on some upcoming slides. Looking at entity enrollment by plan in November, so this is actually post-open enrollment results, we can see that 81% of entities, excluding headcount growth, so this is just looking at enrolled employees from last year to this year, 81% of entities had an overall renewal less than 3.4%, and the highest entity renewal was 3.8%. To continue to improve the quality and efficiency of the care we're offering to our members, we were able to achieve 3.4% without making any benefit decreases at all to the plans. Kaiser Permanente added their Kaiser Permanente at-home care module, reduced the insulin cost share cap to $35 from $75. And then also the short-term disability portfolio was refreshed in light of paid leave Oregon. Next slide, Emily. We don't have too many financials in this deck, but we will just talk a little bit about it. It's a good opportunity also to talk about RSR and the rating actions that we use to achieve 3.4%. I know that they're complex and we'll have the opportunity to continue talking to them over the next couple of months. So overall, the combined medical, dental, and vision renewal, and we look at it that way because that's how the statute looks at it, was 3.4%. That was by design, right? It was very important to us collectively to meet the 3.4% cap. Within that, though, between our medical, dental, and vision carriers, each carrier renewed their own increase. It's based on plan experience. So Kaiser, you might remember, Kaiser's renewal was 4.6% increase. And that reflects the use of rate stabilization reserves to buy down the renewal 1.2%. And they also made a couple of those plan changes. They didn't have any overall impact to the rate, though. For MODA, the final MODA medical renewal was 3.64%. MODA came in a little bit lower for round 3, and so we didn't have to buy down the rate as much. That just reflects a 0.1% buy down. And when we talk about rate buy down, I just want to highlight those are 1-year subsidies to the rate. So we'll be talking again in the next couple of months about continuing that subsidy into the next year, or also how to get the premium rates righted. MODA also, so we've talked about adding VERTA for type 2 diabetes reversal, language services, and Copay Max. They had a couple of operational changes as well. They stopped reimbursing CVS claims. Out of area dependents now have a primary network and receive in-network benefits. And then MODA also replaced the First Health, replaced the PHCS network with the First Health network. And then in terms of, Emily, on the next slide, for the dental and vision renewals, those came in lower than the medical renewals. Kaiser, Delta Dental, and Willamette Dental Group came in at a decrease. Delta Dental was a low increase of 1.26%, and Willamette Dental Group had an increase of 0.85%. The fact that those were lower than 3.4% helped take pressure off the medical renewals. For vision, Kaiser came in at 2.51%. Moda had a decrease to the vision rates of 2.87%, and VSP had a decrease to the vision rates of 12%. Emily, next slide. All right. Please ask questions on this slide too as they come up. This is a slide, we first saw this in March of last year, and we've updated the 2023-24 amount now with our projected spending. So let's just take a look. This is one of OEB's stabilization funds, the Rate Stabilization Reserve, and it was seeded with some surplus savings from Senate Bill 1067 back in the 2019-20 plan year, and then was also increased by $5 million through a strategic renewal decision with the Kaiser medical rates in the 2020-2021 plan year. Over time, we've made a couple of investment decisions to use that money for various clinical and financial initiatives, and those are all documented on the right, and we could just talk about those. Beginning in the 2021-2022 plan year, about $800,000 was invested in Kaiser wellness-based grants and on-site flu clinics, and $2.9 million was used to buy down the Moda renewal. In 2022-23 and also 23-24, we have some of that RSR set aside to pay for Pre-D and OMADA. Those are the pre-diabetes treatment programs. In 23-24, we also made the decision last renewal to begin to pay for Weight Watchers out of the reserve, so that that's not coming out of the, was not in the renewal calc. And then we also used $3.2 million to buy down the renewal increases to achieve 3.4%. So we're projecting that the RSR balance by the end of the 23-24 plan year, so this is what would be available for the 24-25 plan year, will be about $30.6 million. Were there any questions on the RSR?
The feeds that RSR account?
Say that again, Bill. Sorry, I didn't catch the first word.
What are the resources to that RSR account?
Those are monies that came in when we ended up getting the 200% medical care for the hospital. Yeah, that's where that came from.
Okay, so there's no resources to this account essentially.
It doesn't build itself.
Right.
Yeah, it was a one-time pot of gold.
Yep.
And that's the only additional comment that that we'll get to while once we spend this, and if we spend it always towards lowering rates, this eventually when it's gone, you have that year's natural increasing costs, let it be medical inflation, and you have what you've been paying for through the rate stabilization fund. That's the problem. We've actually kind of struggled figuring out how to use this, the rate stabilization fund, in ways that don't really make subsequent years very difficult.
It's like any budget. If you can't use this money for a perpetual spend, right?
Yeah.
So
yeah,
you can.
So we've been looking at it from an investment standpoint. If we can come up with something where if we invest now, and in 2 or 3 years it results in lowered costs, then that's a wise strategic move.
Or you cover until something you're putting money towards starts paying back.
Yeah, exactly. Same. Yeah,
right.
That's what I was trying to say. Yeah. Yeah. Very good. Okay. I agree 100% with Kirsten. This is one of the more complicated topics and issues that we have. So it really is worth making sure that if you have any type of question, there's no bad question or stupid question on this one, because this is complicated stuff. All right, Kirsten.
All right, Emily, next slide, and I'm going to pass it over to John at this point.
Super.
Okay. So here are the goals set for this year, for this renewal cycle. So let's move to the next slide, and then we'll kind of take a deeper dive. So the thing is that renewals are the primary means that the board has to execute its strategy. And, so there are kind of three major areas in that this strategy is going to be executed in: the shift left in member education, the high quality, efficient member first care, and the CAP, of course. So we'll go through these briefly, each one. So the back to basics, some examples here are, emphasizing stress reduction. This is something that came up in the retreat, and making sure that the behavioral health needs of the OEB members are being met. Another example of the back to basics is, coordinating OEB, entity, and carrier wellness initiatives to maximize their impact. And then last but not least is really looking if the funding that's being used for wellness is that is being provided by the carriers today is being done as optimally as possible. So moving over to cardiometabolic, and again, we'll just touch on this briefly because there's a larger discussion of this later today about the GLP-1 coverage for weight loss. Again, these things are covered for type 2 diabetes today, and the consideration is to look into using these, covering these for weight loss. And in that context, it's really, if you're going to cover something like this from weight loss, the thought was that what goes with it is some lifestyle management and some health coaching as well, to make sure that there really is no magic bullet. You need to really have things around these types of programs. And then cancer screening, it's really being more proactive in terms of outreach to members. A good example is colorectal. Making sure that they get their at-home test kits and they get those, those completed. Also, member education around breast cancer, so women understand their risk level, because based on their risk level, there are different things that they might want to be doing in terms of getting mammograms sooner, also getting some genetic testing, as indicated. So that would be another thing, and seeing if there's a tool that's available that would help women with understanding their risk. Skin cancer is another area of interest, just because that is, in terms of the cancers, that is the most frequent one among OEB members. And there's beginning to be interesting tools out there where people can, do some kind of self-assessment in terms of keeping track of the various skin conditions that they have. So, and then lastly is really just making sure that we're tracking the outcomes in terms of these screening interventions. So, and then speaking about interventions is, if you find something, if you have a positive result and no action is taken on it, that's really problematic. So I think the other thing is, broadly looking at intervention following screening, really understanding, what is the time to diagnosis, what is the time to treatment, and what is the outcome. So really looking at all those things. Another key area of interest this renewal cycle is health equity. And we'll also hear something a little later today around doula, the use of doulas and how that reduces, improves the outcomes and reduces costs for OEB and improves outcomes for members. Also looking at some expanding family-friendly building benefits, also virtual plan designs, and enhanced dental benefits for persons with disabilities. So those are the health equity focus. And then moving over to the right here, we have the assess the clinical and financial value of these various programs. And that, that the thought here is really to understand if the clinical and financial value of these programs is really worth keeping them around or modifying them in some way. So let me just pause there, see if there are any questions. Enrique?
Thank you. I just want to acknowledge the work of the team, and it was the first time we had an in-person meeting for me to meet your team and staff, and I appreciate we going back to the basics, comment on teachers and educators and staff on the mental health piece, as we all read and witnessed the Portland Association of Teachers strike and other parts of the state who are facing shortage of educators. I think this is an important component. So I just want to acknowledge that we all took our comments seriously and added them to the strategy, and also the pre-screening for cancer. I know Bonnie and others were also emphasizing that component. So thank you for listening.
Well, we appreciate the feedback from this group, and our job really is to incorporate that into the renewals. And again, all the things that you see on this page have been incorporated into the renewal letters, and those renewal letters will be going out later this week. So the process is well underway. Next slide, please. So a quick thanks to Glenn, who pulled the next two slides to get the information, the next two slides together. So again, what these slides include are those bills that were passed in the last session that impact PEB and OEB. So as you can see, a lot of these are effective, some will be effective before, 2024, but for the most part, they're effective in 2024. And you'll notice that the effective dates for OEB and PEB are different, and that's because a lot of these bills are written in a way that that they're effective the plan year beginning January 1. So that's why you see those differences in terms of when they impact. In terms of the types of bills that you see here, it's really fairly typical. It's around mandated benefits. You're seeing that in terms of, the gender affirming care and orthotics and prosthetics is another area that you're seeing. So it's really making, either introducing or expanding coverage for these things. The other types of bills that, are fairly common are those that are specifying how these things should be covered in terms of cost sharing and the ability to have prior authorization and utilization management. You'll also notice that there's a bill at the bottom of this page that actually addresses the composition of the board. So that kind of gives you a lay of the land in terms of what's on these next two slides.
And John, these will
Yep.
be then part of the renewal process. These mandated changes will be costed out and included in our renewal process.
Right, to understand what the impact will be. Yeah, because as you know, the OEB plans are insured, and as such, they're subject to these state rules. So we can go through the next slide and probably let's just move to the next slide as well. So again, this is really looking at some federal legislation, just kind of switching gears a little bit. So recent years have seen the passage of a fair number of federal laws that are geared towards increasing healthcare price transparency. And ostensibly, the goal here is to promote competition, by making, by bringing greater transparency to pricing. And what you'll notice, though, in practice, this has been fairly challenging. And you'll notice if you read through some of these the concepts here that there have been some delays. So rather than going through everything exhaustively, let's just talk about the gag clause. Sorry, I can't speak. The gag clause as an example, because this is an interesting one. So essentially, beginning in December 27, 2020, health plans could no longer contract with providers who restricted the health plans and by extension, clients, access to de-identified claims, cost and quality information. And again, this is really critical. So it's really not only cost, it's also quality and making sure that this information, that there's no clauses in the contract with the providers that precluded the health plan or its business associates like, PEB and OEB, to access to this information. So this is an annual attestation, and the first one is due the end of this year, and it will cover the period from when the law became effective on December 27th, 2020. So again, just an example. Don't want to spend a lot. I want to be sensitive to the time, and if there's interest, we can definitely take a deeper dive or send out some other additional information on these other ones. But again, just wanted to provide a general sense of some of some of the goals and some of the actions in the federal level around transparency. Okay. If there are no questions, we'll move on to the next slide. And this is really just documenting, where you have guarantees and where you don't have guarantees for multi-year. And as you can see, with the exception of the standard, what you have here, is everybody's going to renew for the 24 to 25 renewal. And even with the standard, we'll be looking at the experience to see if, even if they're in a rate guarantee, we're going to be looking at the experience to understand if any rate action is merited. Okay, next slide. And the purpose of this slide is really to provide the board a preview of what's going to happen in the coming months, and this hopefully will be especially helpful to new members. So the renewal responses will come in after the January meeting. So our focus in January will be to analyze the responses in preparation for the February board meeting, where the first round of renewals will be presented to the board, as well as kind of potential plan design and program changes will also be presented in that meeting. The round 2 requests are released very quickly after that board meeting in February, and will include also any requests for additional information the board has, that they need to make the decision. So you'll have a chance to kind of look at the proposals, figure out if you have enough information, and then we can kind of go back to the plans and the vendors to get that information that you need. So so then we'll have the round 2 renewals presented in March board meeting. And then in the April board meeting, it will be the final rates and the proposed plan design and program changes. So that's really the goal, is getting final board approval in the April meeting. And if that doesn't happen in the first meeting in April, there's always the possibility of a second April meeting if needed. So any questions on the process? And again, the top part is talking about the activities that are underway, and then the important part for the board is the bottom piece, which is really the activities of the board in those coming months, and really their activity, the board activity related to the renewals. Okay. Moving on to the EAP RFP timeline, and this is very timely because this is being released today, which explains why we're particularly busy. So what you see on this slide are really some of the key milestones in that process. A key one being today with it being released, and I just want to acknowledge the efforts of Brian and his team in terms of their collaborating with us to get this going. It's always a major process to get an RFP on the street, and so it's exciting to kind of see this come to fruition today. So it's going out, being released today. The pre-proposal conference is on December 14th, and then responses are due from the proposers on January 26th. And then we're anticipating to have the finalist interviews in the March 2018 to 22 timeframe. And then, that would be followed fairly quickly by the issuance of the notice to award around March 26th. So I think the one thing to understand here is that, some of these dates might change depending on the process. But again, this gives you a general guideline in terms of when these key milestones will be happening. The other thing that I want to point out is really that out of an abundance of caution, that there'll be both a renewal for the AP and an RFP this year. So that's really kind of a belt and suspenders approach, just in case. So with that, any questions? Ali?
Oh, thank you. I was going to talk about this in the director's report, but we do have 3 new board members coming on after Senate's confirmation in February. We're kind of a little bit short until then. It was the first Senate confirmation hearing, and we needed to find JJ's replacement and Jeff's and the local government non-management. So I am excited to say we are going to have a full board as of February, and we'll really need to work to get those new board members up to speed and do a lot of fairly significant onboarding, and just wanted to say how much we appreciate just letting us know, because we will be a little short in numbers up until that point. But yeah, I second Enrique's comment. Mercer really did a great job preparing us for this renewal. Thanks.
Thank you. And I think we're moving on to the next topic.
Okay, in terms of time, we are 10 minutes ahead. Just before we move on, any final questions for Kirsten or for John about the renewal process? Pretty laid out. Things start getting interesting by March, April, but we'll work our way through it. Okay. So I think, Kirsten, is it Christy Ewing going to take us through this one?
Yep, that's right, Tom. Christy Ewing.
Great. Thank you.
Great. Thanks, Tom. And thank you, everybody. So I'm just going to walk us through our discussion about doula services. So for today, what I'm going to touch on is just the background of how we got to where we are today, and then also go through some of our considerations. So for some background, so CIAO convened a research group in the summer of 2023 to review information on doula coverage. And just to provide a little bit more background, in the US, the maternal mortality rate is on the rise since 2019 specifically, and that there is inequities also specifically when we look at different populations. And so that's why it came to CIAO and kind of started that process of us doing this deeper dive. And so this research group was charged, really with looking at the different coverage options, looking at different challenges that might exist, some barriers, and then really looking at, what is the effectiveness and the long-term outcomes of doula services, and is that going to be a benefit to the OEB and PEB members? And just to level set that right now, doula coverage is not currently offered through OEB plans. And then also to provide some background about what is a doula. And so really what we looked at, and so there is a lot of information about, there's birth doula, there's postpartum doula, there's even loss and grievance doulas. And so this is really, as we're talking about it today, is really prenatal birth and postpartum support, because that's what we found was best practice. So when we use the term doula, that's what we're referring to. And so a doula is a non-clinical trained professional who provides this support to the birthing person. In a previous meeting, one of the board members I know really shared that, when you're in birth and labor and delivery, really the clinical team is really focused on the baby, focused on the health and what's going on in that. And so a doula is really there to be the advocate for the birthing person. They're a trusted person that birthing person has gotten to know. They can meet their cultural preferences, either it's language or really knowing what that birthing person wants that experience to be. And then specifically in Oregon, it is doula coverage is offered through Medicaid, and it is required as a certification through the Traditional Health Workers Program. There is a very comprehensive curriculum that doulas need to go through in order to become a certified traditional health worker, and they also have to enroll in the state registry. So if you move to the next slide. So I'm going to dive now into some of our considerations and things that we looked at. So as we started doing our research, some benchmarking. So as I said, so Medicaid does have doula coverage. As of August, there's 11 states that have Medicaid doula coverage, and there's actually 8 more states right now that are in the process of putting it in place. You can see here some of the benefit design ranges. So there's a very wide variety of design, of number of visits, and all of these visits and what we're showing here obviously also include the labor and delivery time. The other thing that's also interesting is there's a very wide variety of reimbursement rates as well. Specifically for Oregon, Oregon has 4 visits plus the labor and delivery as part of what's covered. Oregon actually has one of the highest reimbursement rates, which was just a recent change. Previously, it had one of the lowest rates, but that this year changed to a much higher reimbursement rate. As we look into the commercial coverage space, a couple examples here we just wanted to show is that Providence Swedish does have a program in place. They actually have also an apprentice program, so somebody could pay out of pocket for a doula. And, again, a more experienced doula has a higher reimbursement rate. Within our Mercer Health and Benefits survey, we are finding an increase in the larger organizations that are offering coverage, such as a doula care, also including midwives, birthing centers. And then there's one state, Rhode Island, that requires doula coverage in their fully insured private plans as well as in the Medicaid plan. Moving on to the next slide. So doula services is interesting from a health equity perspective because it is solving, right, for inequities. But we also wanted to make sure, as we did a lot of our research and provided recommendations, that we were looking at some of those other equity considerations, though, for the doulas. And so a couple things that we just highlight here is that within the doula network, we obviously really want to make sure that there's enough doulas in the network to meet the demand so that people who want this care can access it. Partnering with community-based organizations is really important because oftentimes CBOs are the organizations that have a diverse doula provider network and are meeting those cultural and linguistic needs. We also want to just think about funding and training of the doula workforce. There are lots of programs out there right now that offer scholarships and ways to hopefully break down some of those barriers to doulas getting the training that they need. And then again, really important to have a diverse doula network so that we can support, the concordance with the doula and the birthing person. Plan design. This is an area we really just want to look at in our research to make a recommendation of what is the best plan design that's going to support the needs of the birthing person, making sure that there's adequate care, adequate visits, and also supporting equity in pay and time for the doula. Reimbursement, really what the research shows is that, again, we want to make sure there's a fair and competitive reimbursement rates. We also want to make sure there aren't too many barriers to reimbursement. as we all know, navigating our healthcare system, especially as a provider and trying to get reimbursed, can be very challenging. And so, having processes, and even there's doula hubs that will help support doulas navigating this process to get reimbursed. In reporting, it's just really beneficial to have different health equity metrics, of course, related to race, ethnicity, language. A lot of the research showed the need for standardized reporting templates so that you can compare. And then also, one of the primary things that doulas do is in supporting the birthing person is really helping advocate and connect them to resources. So if let's say a birthing person were needing mental health support, that doula is that trusted person who can know what's available for resources and connect them to that. And so having reporting on what type of referrals and where those are going is another important component. And then lastly, within communications, it's just really making sure that communications are accessible, that there is support for members connecting. And then lastly, but one of the most important, is really communicating to providers and the clinical team what the benefit of a doula is, and really supporting that collaborative relationship between the doula and the clinical care team. Moving on to the next slide, please. So some clinical considerations here. And so the first bullet point I have here, I know is super broad. And so this was a cost-effective analysis that was done. And it was based on 1.8 million women. And basically this was for first births within the US. And they really were just trying to kind of come up with a cost analysis for doulas, knowing that the data is limited. And essentially, they came up with it was a $1,452 cost effectiveness for women with their first birth that used a doula. And it also had an impact on the second and third births for specific women. Then the other clinical considerations here that I wanted to call out, and most of the research is in the Medicaid population, but that there is, you can see here, reduction in C-section, there's reduction in the use of pain medications, fewer negative birth experiences, just in a birthing person's, satisfaction with what that experience was like. There's also decreased rate of postpartum depression. And then also there's benefits to the baby as well. So higher APGAR scores, and then increased breastfeeding rates. Next slide, please. And so as we looked at all of this information, we took the OEB and PEB population. And so this is for OEB specifically here, but so we use the reimbursement rates that are currently in place for Medicaid, which is the $215 per visit, and then $640 for that delivery time period. And so option one is 4 visits plus that labor and delivery. And this option is here because this is currently what's in place for the Medicaid doula coverage. And for that option, there's no net cost impact. Option 2 here is presented as 8 visits plus that birth and delivery, again at those same reimbursement rates. And the 8 visits is really what has been found to be a good middle of the road coverage that provides the doula with enough time and reimbursement for the time that they actually spent with the birthing person. Some of the research showed that doulas will on average spend about 32 hours direct patient time. And so again, we want to think about the equity for the doulas and making sure that they are being reimbursed equitably, and that the coverage is enough to provide those services to really have those clinical outcomes that we see. And so you can see here, so then that option 2, the 8 visits, has a 0.01% net cost increase. A couple things that I just want to point out with that net cost increase. So we used a 30% reduction in C-sections for the OEB population. We used a 22% reduction in preterm births. and we assumed about a 15% utilization of doula services for the population of those, and of course using, what the birth rates have been over the population. So I'm going to just pause there and see, Tom, I see you have your hand up.
Yeah, the question is rate. If I'm looking at option 2, and at CIAL, we talked about this, and while we didn't have a quorum with CIAL members, we had at this point also some PEB participation, and there was the agreement was that option 2 is the better. The 0.01% increase, was that the same across our 2 plans, or was that differentiated? Was it just a total cost? Or the assumption that both MODA and Kaiser would have the same rate experience?
It was very, very close. There was very,
Okay,
yeah, it was very close.
That's
so
great.
this was kind of the
Great.
average of the 2, but
yeah. And the other conversation that I think we the only additional conversation at CIAL that made sense to, at least for the board, your assumptions around the reduced C-section and preterm birth is, those are assumptions, and you have something backing it up. What is unclear is what happens with utilization, and we just don't know what's going to happen there. The other part is there's all these downstream effects. We're hoping that that there is serious shifting left with this process. If you reduce preterm births, prematurity, that pays out when the kid is 2, and when the kid's 5, and when the kid's 10. If you deal with postpartum depression, you mitigate all sorts of problems a year, 2, 5 years down the way. So this, while I appreciate what you've done, which is in your analysis, try to keep it as kind of tight as you can. This is one of those that has significant opportunity in the downstream that you
Thanks,
can't
Tom.
quantify right now.
Yeah, and I think you're getting to that point. There are, as I listed before, all of those benefits, but it was really hard to quantify and to recognize there's many other factors in some of those things as well. So we used the 2 data points that we felt, we could use to do the cost analysis. One other point I just wanted to say too is that we have consulted with OHP and just asked, how is the program going? What were your learnings? Things like that. And that also has come into this recommendation, or the 8 visits really, overwhelmingly, they said that the 4 visits is just not enough.
In terms of comments, Bill, you were on the work group for this over the summer. I'd love to have your comments and opinions.
So I was your OEB rep on this. I learned an amazing amount of things that I probably should have known about 22 years ago and didn't. And but it was very good. What I took away from this, though, the most was, the data was pretty clear from we got the numbers in and how much it was being there. But we had a lot of testimonial from women who used doula services, and sorry, I should say birthing parent who used doula services. One thing we got corrected on during our meetings was how to use the appropriate language. The really strong stories of how doulas really helped at all 3 phases, prenatal, birth, and postpartum. Some of those stories will live with me forever. In just this service and how much it made the entire process much more palatable, much more successful, much safer. So we recommend we adopt this coverage for option 2.
Yeah, and in terms of process, CAL will, I think we'll meet one more time to do a final official stamp of approval, and the board will be taking this on, I believe, in January to whether or not they choose to approve it. Maybe it's February, but you'll be getting a formal. We wanted to open the conversation so that you knew what was coming down the road on this one.
Mm-hmm. Thanks, Tom.
Okay.
And I think,
yeah. Go ahead.
I was just going to say, I think this will be part of the whole renewal process so that the board will have all of the financial information from all the other aspects before being asked to make a decision.
Great. Thank you. Any other comment anyone wants to make around the doula process? Okay. I think we are now at break time. I have 2:19. I would like to reconvene at 2:30. All righty. Okay, I have it at 2:30. Are we reconvened? We'll launch. Okay. What we're going to now, we have an hour to talk about GLP-1 weight loss drugs. And the only thing I can say is the board is about to get the short version of it. When I say that, a little bit in jest, but we spent over 2 hours discussing this topic today with Xiao. And we tried to get down into the weeds. The hope for this conversation is that the board, the rest of the board members will be able to understand the complexities around this issue. And I'm assuming that all board members have read the public comment that we've had. We will talk a little bit about that and weave it into our conversation over the next hour. So with that, I'm going to, is it Sarah, are you going to start us, or Kirsten?
Yep.
What's the
Yep,
rhythm?
I can start, Tom.
Super, thank you.
Okay, so why are we talking about GLP-1s? I think we all know obesity and cardiometabolic disease. It's a challenging, it's a chronic disease, and many people in the U.S., including many OEB members, have spent months, years, maybe decades trying to treat it with various regimens of diet, exercise, and perhaps even prescription drugs or supplements marketed for weight loss. And yet they still haven't achieved their health goals. And so these drugs represent a new tool in the toolbox that people haven't yet had the opportunity to try due to a combination of both availability and cost factors. And they're understandably eager to try them. And you can feel that sense of urgency in those public comments that were submitted. At the same time, the discussion of coverage needs to acknowledge that successful treatment of this complex and chronic disease that is obesity generally cannot be accomplished through the use of drugs alone. We need to continue to recognize the environmental, social, lifestyle factors that have contributed to the rise in cardiometabolic disease in our society, in our workplaces. And we need to think about how we can continue to move upstream and shift left to help people be successful in maintaining that healthy cardiometabolic state over time and prevent more people from developing obesity and cardiometabolic disease. So with that, we can get started with just a little bit of background here. A brief overview of what a GLP-1 drug is. GLP-1 stands for glucagon-like peptide, and a GLP-1 is a hormone that's produced in the intestine in response to the presence of food. That hormone increases the production and release of insulin, and it increases the feeling of being full during and between meals. This class of GLP-1 drugs isn't new. There's been various products on the market for the treatment of type 2 diabetes for over 15 years now. Initially, there were products that had to be given every day. These newer products that are available now are given as a once-a-week injection. More recently, we've seen some GLP-1 drugs promoted for weight loss. So the FDA approved Wegovy to be used for weight loss in conjunction with diet and exercise back in 2021. And just last month, Zepbound was approved by the FDA. As of today, OEB excludes the coverage of weight loss drugs, including the GLP-1s, and that same exclusion applies in PEB and Medicare and Oregon Medicaid. There's a lot of complex considerations associated with the decision to add or defer coverage of these drugs for weight loss, and we talked through a lot of them this morning in CIO, and we're going to talk through some of them a little more briefly today. The drugs have potential to be part of a regimen that can help people move towards health, but at the same time, there's safety considerations as well as cost factors that need to be explored. We can go to the next slide. So similarly with doula, there was a summer research group formed to study some of the more complex considerations around the GLP-1 coverage. We heard Kirsten talk earlier about the focus on shifting left, including the cardiometabolic treatment spectrum. And so as part of that spectrum, we recognized the development and increased utilization of the GLP-1 drugs in this area. So bringing it to the summer work group, we had an opportunity to study it in depth. And we also were able to include participation from OEB as well as PEB. The group met several times over the summer, and it included participation from the carriers, state staff, Mercer, and both boards. And just to clarify, the GLP-1 drugs are currently covered in OEB when used for the treatment of type 2 diabetes. So the focus on the research group was exclusively looking at the use of the drugs for obesity treatment. We go to the next slide. So this slide has just a little bit more detail on who participated in the research group and what was considered through that process. Broadly, the group looked at putting together coverage policy options and also considered how the GLP-1 drugs fit into the overall treatment spectrum for cardiometabolic disease. And the group explored a wide range of clinical considerations, and you can see many of them listed here. That list is not all-encompassing. There was a lot of discussion. The group focused on coverage and treatment for adults. It did not delve into coverage for children or adolescents, and the group didn't weigh in on specific lifestyle modification programs. Let's go to the next slide. This slide just gives an overview of the current coverage landscape. And while it's true that some payers, including some payers in your region, are covering the GLP-1 drugs for weight loss, the majority of Americans still currently do not have coverage. Only about 35% of private employers are currently covering the GLP-1 drugs for weight loss. And a lot of that limitation is due to concerns about cost growth. There are some public employers adding coverage. For example, you'll see here Connecticut, Idaho, and Florida are adding coverage, but it'll be available only through the state's selected lifestyle management vendor. Other states like Delaware and Idaho are smaller, but they're adding coverage as well. They're relatively small. I want to note North Carolina and Iowa previously covered the GLP-1 drugs for weight loss, but they've made the decision to discontinue covering due to the unanticipated demand for the products. So the costs were much higher than what they projected. And so even though they had added coverage, they actually had to pare that back. And so they won't be covering the drugs moving forward. Individual and small group plans like on the ACA exchange generally do not cover weight loss drugs. Medicare is actually prohibited from covering the drugs due to a 2003 statute. There's a lot of groups out there advocating for a change there, but as of today, there's no coverage in Medicare, and state Medicaid programs have the option to cover or exclude. As of today, Oregon Medicaid does not cover, but they are exploring coverage, and there is, I believe, a series of meetings coming in January where Oregon Medicaid is exploring adding coverage for individuals over the age of 21. We go to the next slide. This slide is around consumer demand, and it probably doesn't need a lot of explanation. I can say in many years of pharmacy experience, I don't think I've ever seen this level of consumer interest and excitement about any class of drugs or any single drug. The Kaiser Family Foundation, which is not affiliated with Kaiser Health Plan, they conducted a survey in July of this year on the public's views on the new weight loss drugs. And they did a representative sample of about 1,400 adults in the US. The survey was done in both English and Spanish. And what they found was pretty surprising. They found 68% of people who wanted to lose 20 or more pounds would be interested in taking a drug for weight loss if it were found to be safe and effective. Half of people trying to lose up to 20 pounds. And maybe most interestingly, 23% of people who are not even trying to lose weight said they would be interested in taking a drug. So what's driving the demand here? I think it's a number of factors. There's a high and growing prevalence of obesity, and you'll see some data a little bit later in the presentation. A lot of people are seeking to lose weight, and they feel that the advice that's been given to them to date, eat less, exercise more, just isn't working. And we also have to consider the effect of social media and advertising. So you can see some statistics here, over 500 million spent halfway through 2023. And the spending on Wegovy is up by 1,000%. So drug companies, they're really good at marketing. They know what they're doing it well. And these drugs are just getting a lot of press and a lot of discussion. Let's go to the next slide. And that's not just coming from consumers. Healthcare providers are really interested in adding coverage of these drugs as well. Medical providers are adding for coverage. The Oregon Medical Association, in their public comments, they're supporting coverage for the GLP-1 drugs and they're requesting removal of the exclusionary language to give plans the option to cover. Also have to note that the AMA also recently passed a resolution calling for what they're calling health insurance coverage parity for clinically validated obesity treatments, which would include products like Wegovy and Zepbound that are FDA approved. We go to the next slide. So when we hear about FDA approved, like what's an FDA approved label or the labeled indication, this slide here is just going to help us make sure we're all on the same page in terms of what we mean by that. So when the FDA approves a drug for use, they approve the labeling, and that includes the packaging the drug comes in and the prescribing information, which is known as the labeling for healthcare professionals. All of the labeling needs to be proposed by the manufacturer and then approved by the FDA before a drug can be marketed for use in the United States. So what you see here on the right is just an excerpt from the Wegovy label or the Wegovy prescribing information. And it's the indications and usage section and the dosage and administration section. And the label also includes a lot of additional information you don't see here, such as warnings and details on the clinical trials that were conducted. But in this indications and use section, it tells you what populations and for what indications the drug should be prescribed for, what it's approved for. So I think of it as the FDA label indicates the population and the conditions under which the drug was actually proven to be safe and effective in the clinical studies that were submitted to the FDA. So in this case, Wegovy has been proven effective in the populations you see listed here for weight management as an adjunct to lifestyle changes like reduced caloric intake and increased activity. Now, the manufacturer of the drug might point to that labeled indication as part of their price negotiation strategy, and that's something we need to keep in mind as well. So just for example, I've seen several cases where there's employers or groups that would like to cover a drug like Wegovy, but maybe only for the highest risk individuals. So maybe people that have a BMI of 40 or more. And the manufacturer will come back and say, unless you cover the product for everyone for whom the drug is indicated on the label, we're not going to offer discounts in the form of rebates. And so it's important to understand the label. It's both an informative tool on when and for whom the drug is actually proven to work, and it's also used in marketing and pricing negotiations. Also, just want to note here, once a drug is approved by the FDA for any specific use or for any specific population, there's no requirement for prescribers to limit their prescribing only in accordance with the label. So we've heard a lot about off-label prescribing, and that's when a prescriber will write a prescription for a patient who doesn't meet the criteria for the FDA label. So for example, Ozempic's FDA label indicates it's approved for improved glycemic control in people with type 2 diabetes and reduction of cardiovascular risk in patients with type 2 diabetes. However, prescribers can and do prescribe Ozempic for weight loss, even though it's not on the FDA label. That said, most payers do take the action of limiting the coverage to the FDA approved indications, and that's how the OEB coverage is structured today. So before we go on, I just wanted to stop and see if there were any questions about the FDA label, because it does come up a lot. Okay, we can keep going. So just This slide is just about the market for GLP-1s and the universe of drugs and kind of the market basket in which drugs like Wegovy sit. So Wegovy is not the only GLP-1 drug out there for weight loss, but it is the one that is most talked about right now. There's other drugs that have an FDA approved indication or FDA label for weight loss, and you can see those listed there. Zepbound was just approved last month, and that includes it's the same active ingredient as Mounjaro. It's marketed for weight loss as Zepbound. There's also some older products. There's Contrave, Qsymia, and then there's generic formulations of phentermine. And those are actually the most commonly prescribed drug products for treatment of obesity today. And they're pretty low cost, under about $20 a month. All this to say, this is the beginning and not the end of all of the GLP-1 wave. There's at least 12 more drugs in development, including some orally administered options. We're hoping that additional competition is going to bring down prices over time, but that's not going to happen today. It's not going to happen tomorrow. It's something that's probably going to happen over the next several years. Also have to note, not on the slide, there's other products out there that are not FDA approved, including products that are made by compounding pharmacies. And I think someone even mentioned that in one of the public comments. These pharmacies are under limited regulation. It's kind of a quasi-legal space. I would never recommend the use of a compounding pharmacy for GLP-1 drug. The drugs have been found in some cases to be counterfeit, adulterated. They might have extra chemicals in them. I know people are doing it, and I think it speaks to just the feelings of desperation. People want to try the drugs, and so they're going out and purchasing them however they can. They want to try something new, and the products that are approved by the FDA are deemed as unaffordable, especially without coverage. With that, I'm going to turn it over to Dr. Chuang, who's going to talk a little bit about some of the clinical considerations and the context of these drugs in the spectrum of other treatments for obesity.
Thank you, Sarah. Next slide, please. So I think it's important to put in context the GLP-1 medication, because it is an additional quiver for the physician in their medical toolkit when it comes to treating weight loss. And as I kind of go through the treatment options and continuum, let me just sort of state that, as much as we're discussing the reduction of weight, the weight is really sort of the outward manifestation of the cardiometabolic dysregulation that's physiologically detrimental to health, right? So it is that cardiometabolic dysregulation that leads to type 2 diabetes, for example, which could end up being on GLP-1 medications also, or that can progress onwards to heart disease, stroke, kidney failure, etc. So as we're talking here, the intervention around weight loss, it is through that process that we're really trying to reset the metabolism to push back against insulin resistance as much as we can, and to optimize glucose regulation, et cetera, et cetera. So where GLP-1 medication sits, it is more on the aggressive end of treatment options, so more to the right side. The more aggressive one current to date has been around bariatric surgery, right? So it's a procedure, and it's going to alter your anatomy as the approach. So GLP-1 medication literally sits right next to it on the aggressive treatment option end. But let's start from the left side, right? So fundamental to approach to improve cardiometabolism is addressing nutrition or optimizing nutrition, optimizing physical activity, and other factors such as improving sleep, improving mental resilience and fitness, because we know all those things impact metabolism positively or negatively. So historically, we've had traditional diet and exercise programs from carriers or vendors. The impact as measured by weight loss at 1 year is nominal, right? So they're between 0 to 5. However, the cost is also relatively nominal in the sense that these programs cost around $500 plus or minus, basically in the 3 digits on an annualized basis. However, they're recurring cost. Research into the DPP program, or the Diabetes Prevention Program, has shown consistent positive impact in the range of 5 to 7%. This is the CDC sort of approved, certified program that some vendors and carriers offer, and they get reviewed and to ensure that the process is aligned with this research and that the metrics that are being tracked and reported on align with what the expectations are. So at 5 to 7%, a little bit better. However, the annualized cost for this treatment tends to be a little bit more as well. Now we move into sort of the medication-based approach to treatment. It may or may not improve actual annualized weight loss in terms of a metric. However, the cost becomes significantly higher in the ranges of 3 figures to 4 figures on an annualized cost basis. And those are the medications such as glycemia, Contrave, etc. Right next to it, but a significant impact in terms of the weight loss, is the GLP-1 medications focusing on clinical weight loss. The cost is also significantly more, ranging between $11,000 to $16,000 a year prior to rebates. But some of the medications like Wegovy are able to achieve 15+% weight loss. And now with Zepbound, they're reporting the ability to achieve a 20+% weight loss. So at 20%, now we're achieving the same level of weight reduction as the bariatric surgery from a comparison basis. Keep in mind that the GLP medication is an annual cost, and to maintain or persist that benefit, it may be an ongoing treatment cost on an annualized basis, whereas the surgery, it's going to be sort of a one-time significant cost of the procedure, around $20,000 plus or minus. So that's important to keep in mind, that there is a continuum. Not everybody needs the more aggressive weight loss or the aggressive treatment options. And some folks are not going to be able to achieve what we call clinically meaningful weight loss, greater than 5 or more percent, by doing the behavioral modification intensive lifestyle approach. And just to summarize to a previous slide, what we're seeing across employers is around 35% of employers covering GLP-1s for obesity management. Some are adding them, some are discontinuing the coverage due to cost overrun, but it's around 35%, and that percentage continues to increase is what we're seeing. And it tends to be increasing more on the larger employer groups as well. So something to keep in mind. Next slide. So when it comes to the prevalence of obesity, we actually do not know the exact number for the OEBB population because through claims data, it is not one that is reliably and consistently tracked and reported. So it remains largely undiagnosed from a data and analytics perspective from the claims side. And much of the weight data is being self-reported as a source. So again, we have to take that with a grain of salt in terms of the accuracy and reliability of that as well. However, Kaiser does tend to collect BMI as part of their routine vital signs, weight and height, and the calculation of the BMI as part of their care process. So we do have more data about their population. It's about 58% of its members have BMI data that we can analyze and categorize, and it allows us to track and get a sense of overweight as well as the obesity classes 1, 2, and 3. That being said, at least based on 58% of available data across the membership from last year, it's about 46.5% of those members that are measured had a BMI of 30 plus. So that's the obese categories of 1, 2, and 3. When we include overweight members as well, the total prevalence rate increases to about 77.5%. So how does that compare with larger population statistics sources? So when we look at national prevalence of obesity by state statistics, Oregon reports about 30.9% overall for BMI 30 plus. So that's the obese range. So that is a little lower than what we're seeing through Kaiser, but bear in mind that for Kaiser, it is a subset of the overall membership. And then if we look at the distribution across the various levels of BMI, from overweight through to the obese categories, we see the percentages on the graph to the right. Another population that we know has increasing prevalence of obesity is in the pediatric, the population of children and adolescents. So that data is similarly not well quantified for the OEB population. We do know it is an increasing percentage. That's a national trend, but we don't have concrete quantitative figures for that. So this is important to sort of use in our analysis and in our estimation of the potential population that could benefit from this medication. Again, the actual decision to treat is a clinical decision between the prescribing physician and the member. But in terms of hitting the BMI as a one parameter, this would give us some indication of the potential volume of patients. Next slide. The final slide that I'll speak to is just around the clinical considerations of around obesity management and GLP-1s. Although we have longer and more experience with the GLP-1 medications for treatment of type 2 diabetes, the use of these medications specifically focused on weight loss and weight management is a shorter time frame. The studies that the pharmacies have, pharmaceutical companies have used have tried to just show within an 18 or 24-month time frame that they were able to achieve the weight reductions that I reported on. And typically that has always been in conjunction with diet and physical activity programs in parallel. All we know is it works until 18 or 24 months. Longer term studies and insights about how members are using medication for a protracted period of time, the potential for lingering side effects, or the potential for new side effects, albeit less common, are things that yet to be unearthed, and they only come through long-term studies as the population and the utilization increases. So those will be data that will still be coming, and that's something to keep in mind. The labeled indication for coverage for 12 and older, that's a population is even less data that is available, less experience. The American Academy of Pediatrics just updated their clinical guidelines for the treatment of pediatric obesity in January of this year, and they included GLP-1s as a clinical consideration, but this is something that's still evolving as well. So again, something to keep in mind as we discuss GLP-1 coverage. And I like to just re-emphasize that the importance of the optimal outcome that I was reporting were based on studies and based on experience that shows that GLP-1 has to be used in conjunction with other programs that address the nutritional aspect, physical activity, and ideally mental health and sleep to achieve the maximum benefits as goal number one. But then two, the potential that once the ideal weight is achieved, that options can be considered for whether the individual can come off GLP-1s, use other treatment options, or just rely on their behavioral modification that's taken place. So a lot of this is still in flux. What is possible versus what is well studied is a gap, and that's things that are being considered by various experts in obesity treatment currently. The pent-up demand is something that's impacting the supply chain. It can have a negative impact on those with type 2 diabetes that are using GLP-1 medications for treatment of diabetes that end up being used in an off-label context for treatment of obesity when obesity medications are not covered and we don't have any sort of process to review prescriptions for those GLP-1 medications FDA approved for type 2 diabetes. So those are things to consider in the structure and process of coverage. The last thing that I will just mention is, the duration of therapy. This is the biggest and unknown. The assumption is if nothing else changes and the only benefit that we're seeing is solely from these medications, then the expectation is to maintain the improvement in weight and cardiometabolic metabolism is going to be the persistent use of these medications, requiring weekly injections at a cost, requiring the individuals as well as the physician to work through the side effects and the dosing adjustments that may need to take place, etc. To assess whether they achieve the ideal clinically meaningful weight loss, because only 85%, 75 to 85% actually benefit from the medications when used appropriately. So some will not respond. We need to know who they are. We need to change their approach and discontinue the medication so we're not using it unnecessarily. So all those things become considerations that over time we will have a better understanding. But these are sort of the real human aspects of chronic medication treatment that commonly comes into play. However, because this medication is so expensive, the impact is both a clinical one as well as a financial one. So, no, I've covered a lot on the clinical considerations, and that is why this topic is not an easy one, and there are many factors to consider as well. Let me hand this off to Kristen.
Thanks, Ian. You set this up perfectly by mentioning that the GLP-1 conversation is really talking about the clinical aspect of coverage and the financial aspect of coverage at the same time. Emily, if you go forward one slide. So for the rest of the discussion today, we'll focus on benefit and cost considerations and just learn a little bit more about the financial complexities of offering coverage and talk about some potential timeframe options. So we'll just walk through some benefit considerations to keep in mind, and then we'll look at some actual financial numbers and some coverage options. As Sarah mentioned, some states have mentioned that they're going to be offering coverage either just according to the label or also exclusively through a lifestyle management vendor, at the same time that other states are announcing that they're discontinuing coverage because costs have come in much higher than they anticipated, and they have to regroup and figure out a more affordable, sustainable way to offer coverage for the long term. We feel like one benefit consideration here is, however we decide to introduce coverage of GLP-1 drugs, doing it in a way where we're not in a position to soon after offering coverage have to walk it back and interrupt current treatment. Rebates are a critical consideration. Sarah walked us through a drug label and talked about the importance of offering coverage that doesn't contradict the indication of the label. Rebates are a meaningful discount off of the list price of these GLP-1 drugs. They reduce the cost more than half. That's a tremendously important discount for our plan and also for our members. So whatever we do for coverage policy, we need to keep the FDA label in mind. We're going to be presenting some cost impacts, and I know from experience there's the risk that when we present cost impacts, especially, some of them are even in bold and they're on a screen, they look like they're really certain. So we just want to highlight ahead of time that there's more that we don't know than we know at this point, which is really true of any novel therapy, because we haven't had history under our belt to see how many people actually use the drugs. And also, there hasn't been much time for the market to mature. We know that there are new entrants, new drugs coming available all the time, and we expect more here in the near future. So while we show some impacts, the price of the drug is actually unknown. We're using our best estimate of a net price of a drug. We don't know the actual prevalence of obesity in the OEB population. That's something that Ian just mentioned because it is undiagnosed in the claims data. We have to extrapolate between a couple of different data sources. We're using something that's in between the CDC data for Oregon and the Kaiser data for the OEB population. So maybe prevalence of obesity could be higher, maybe it could be lower. We have to assume an uptake when we do a financial estimate. And what I mean by uptake is not everybody who is eligible for a drug is going to take it. The GLP-1 drugs currently require a weekly injection that's self-administered. Maybe that won't appeal to certain people. And if we offer the drug coverage exclusively through a lifestyle modification vendor, and we'll talk about that more, you know, perhaps some people aren't interested in making concurrent lifestyle modifications as they take the GLP-1 drug. Duration of therapy is an important factor. If you're a drug manufacturer, you're saying, hey, people have to take this drug for a lifetime. Emerging evidence suggests that that's not true, maybe because of the injection aspect of the drug or because of the gastrointestinal side effects. The duration of therapy seems to be shorter than a year. We have to assume something when we come up with a financial estimate. So we're coming in right in the middle at an average duration of therapy of 6 months. Again, that could be higher. We also don't know the net cost of the drug post rebates. And again, that's going to be largely related to the timing of when we offer coverage. The longer we delay coverage, the higher likelihood that we're letting the market stabilize and a lower cost alternative come to market, become available. And also, of course, the number of people taking the drug and the cost of the drug coverage will be influenced by what ultimate benefit design we attach to the drug coverage. If it follows normal prescription cost sharing, if we decide the only affordable way to start introducing coverage is with a higher cost share or some kind of annual limit, that might influence the number of people taking the drug as well. So just, you know, the takeaway is that the financial estimates that you're going to see, it's Mercer's best thinking at this time. And as we know, with situations like this, you know, we'll watch this situation emerge over the next few months and have the opportunity to revise financial impacts as we work through the renewal process. But please just understand that the financials we're going to see their estimates, they're not certain at this point. The other point, it's one of the many reasons that we're talking about the financial impact as well, is that OEB is subject to the 3.4% budget cap. And we talked about that during the renewal primer that limits the overall renewal increase for medical, dental, and vision combined to 3.4% per year. And OEB has successfully been able to meet the 3.4% requirement through a combination of strategic decision-making, value-based payments, and other innovative payment schemes for providers. Also, you know, leading edge care management. So we've been able to come in at 3.4%, but you'll notice that we have not also been able to add any material benefit enhancements. So for example, we haven't been able to add an expanded infertility benefit or other family building benefits because there just is no flexibility in the 3.4% requirement to look ahead to long-term clinical savings or for exceptional new therapies. So it's just something to keep in mind as we talk about how to offer GLP-1 coverage. How can we do this in a way that is financially sustainable and also really emphasizes long-term sustained impacts for our members? Emily, next slide. I just want to mention briefly cost share dynamics so we can just keep a couple points in mind. Don't try to remember this, but we will revisit more in detail for the renewal. And I think that the takeaway here is that HSA members will feel the cost of these drugs differently than PPO members because our HSA members, provided they have not already met the out-of-pocket maximum and excluding any HSA contribution from their entity, HSA members will have to meet the deductible first. And due to the price point of the drug, before rebates, maybe around $1,000 a month, after rebates, somewhere in the ballpark of $500 to $600 a month. If you have a 20% HSA coinsurance and you haven't met your deductible yet, your monthly copay could be around $100 a month. There are coupons available, just to make the picture even more complicated, up to $225 a month. So potentially members wouldn't be paying anything out of pocket. But as we go forward through the renewal process, we'll just want to keep in mind that our PPO and HSA members will feel this a little bit differently. Emily, next slide. There are a couple different cost impacts to think about. For somebody who is eligible for the drug and decides with their physician that it's the right course of treatment for them, presumably their cost would be the out-of-pocket cost for the drug on an ongoing basis, and then the physician office visit needed to get the prescription. We also have two other sources of costs that we want to keep in mind. If the coverage results in an overall premium impact, that's something that would impact all members within OEB. And then if in order to also offer coverage and meet 3.4%, we had to look to benefit changes or reductions, people could see an increase in cost share resulting from those benefit reductions. But just keep in mind, there's a couple different moving pieces here that impact our members related to GLP-1 coverage, both directly and also indirectly. Next slide, Emily. All right. I think I'm just realizing I didn't take the PEB slide out of this one. I apologize for that. We talked about it in CIA this morning because the joint work group studied for both boards. But today we'll just focus on the OEB data. So this slide just looks at a potential upper bound, and even within that, there's still some uncertainty with regard to, hey, how high could costs be? In this scenario, we're really trying to understand if everybody who is eligible took the drug, what kind of costs could we expect? And even here, there are some things we don't know. Prevalence is a key assumption for GLP-1 drugs. That is the percentage of OEB's population that would meet the age and BMI threshold. That was a BMI of 30 plus or 27 plus with at least one comorbidity and members aged 12 and older. So within that cohort, there are 45,691 OEB members we're estimating. Could be higher, could be lower, as we talked about. Assuming an average drug price net of rebates of $500 to $600 and an average duration of treatment of 6 months per year. We kind of talked about the uncertainty in those. It's just our best thinking as of today. The cost to provide coverage for everybody in this scenario would be around $140 million a year, which is slightly over 15% of premium. Just to illustrate the unique nature of GLP-1 drug coverage, in that not only is it expensive, but it impacts a tremendous portion of the population. I feel like we don't typically talk about benefits that impact even more than, single digits percentage of the population, let alone, more than 30%. The bottom bullet incorporates a more reasonable uptake rate. We talked about reasons why the whole OEB population, even if they're eligible, wouldn't take the drug. And I hadn't even mentioned, the out-of-pocket cost may still not be affordable for some members. Mercer's best thinking at this time is maybe 15% of the eligible population would decide to take the GLP-1 for an average of 6 months per year. And in that scenario, we'd be looking at around $21 million a year, which is 2.3% of premium. So I know the financial stuff can get kind of heavy. I'll pause for a minute before we keep going and see if anybody has any questions. Okay, saving them all for the end.
I just have a comment. That's a lot of money.
Yeah, yes. It's a unique benefit in how many people it could potentially reach. On the one hand, it highlights the nature of the need as well. That we're talking about giving coverage for a benefit that could impact 40% of a population. We just need to figure out how to do it in an affordable, sustainable way.
Could another question, could OEB and PEB go together and buy a pharmaceutical company and make it on their own?
Yeah, it's tempting to think that way, Tom.
I think she was downplaying that making your own drugs, right?
You can't do you would need to do the clinical trials, submit to the FDA. You could do it. It would take a decade or more.
Could get a warehouse and start a remix pharmacy.
So Emily, let's skip the PEB slide and go to the one after that. Thank you. Okay, so we're going to look at a couple of coverage options. We're going to look at a strategy that focuses on readiness and preparedness in year 1 and coverage in year 2 that's focused on optimizing member success and sustained long-term outcomes. We'll look at a coverage that's more permissive and doesn't require lifestyle modification. We'll look at a scenario that does include lifestyle modification. And then also we'll talk about what happens when we try to limit to our higher acuity members through a higher BMI threshold. So this scenario, we just wanted to put this out there. To cut to the chase, this scenario is Mercer's recommendation, actually, and we're calling it a readiness/preparedness scenario. And it's really in recognition of all of the factors being discussed today, especially what Dr. Chuang touched on, which is we have to offer GLP-1 drug coverage if our goal is sustained long-term outcome. So it's not member takes the drug, loses weight, stops taking the drug, gains the weight, takes the drug again, loses the weight, and so forth. If we're really going for sustained long-term outcomes, the member must be supported with lifestyle modification. What we mean by that is different eating and exercise patterns, as well as support with sleep and mental resiliency. That ecosystem will take a while to put in place if we want it to be a cutting edge ecosystem. The additional benefit of more time is that we give the market a chance to stabilize, and for drug prices potentially come down, we also let the supply constraints work themselves out. And that's why you'll see no cost impact for the 2024-25 plan year in this scenario, because this is really looking at focusing on waiting for the GLP-1 coverage for 25-26 and then getting ready next year. And I just want to highlight too, it doesn't mean we're not doing anything in the meantime. We're also looking, and you'll see these coming up through the renewal process. We're looking at adding additional weight loss vendors to complement the offering that Weight Watchers brings to our members, because we know, not every member wants to have the same solution. We're also looking at promoting health coaching as a way to help members who maybe haven't fully recognized that they could benefit from a program like this, or they have recognized that they could benefit from a program like this, but don't necessarily know if they can commit and go through with it. Health coaching really fills that need in getting members ready. So those are all activities that we can be working on next year as we get ready for coverage the following year. Emily, next slide. In this scenario, we look at coverage according to the label, but without the requirement of ongoing participation in the lifestyle modification program. So in this scenario, we estimate 15 to 20% uptake. So people who are eligible, how many people would take the drug for an average of 6 months of treatment per benefit year. The cost impact to OEB would range from 2.3 to 3.1% of premium, we think, in that scenario. Emily, next slide. So one early idea that was circulated, it was certainly well-intentioned, was, if we have to create an on-ramp for full coverage and consider a phased-in approach, does it make sense to start with our higher acuity members? For example, if we target individuals who otherwise might have bariatric surgery, does the financial equation start to make more sense? Unfortunately, our financial modeling really shows that that's not the case, because once we start adding criteria that's not included in the FDA label, we lose eligibility for rebates and the per script cost more than doubles. at this point in time anyway. So we can look, we have two scenarios here to talk through. One is having a minimum BMI threshold of 35 or higher. And then the other is having a BMI threshold of 40 or higher. And the bariatric surgery threshold used to be 40. It was recently lowered to 35 or higher. The range of OEB costs might be 29 million to 17 million. We think within those populations, the uptake would be higher than if we're just looking at the overall population. And Emily, next slide. So covering according to the label with lifestyle modification. So the label does allow use of lifestyle modification, concurrent exercise and nutrition, education and change in conjunction with the drug therapy. So we're still eligible for rebates in this scenario. And then the benefit really is to the member and having this being surrounded by an ecosystem of extra support so that they can just go through therapy once and then ideally have sustained outcomes. In this scenario, we're assuming a slightly lower uptake rate, so 10% instead of 15%. And then the financial impact is 21%, or sorry, $21 million, 2.3% for OEB. We are assuming a slightly longer duration of therapy of 9 months in this scenario, just thinking that if members are guided and having better success and that treatment pathway is really facilitated, they might stay on the drug a little bit longer. And Emily, last slide. Something to keep in mind, and certainly not a longer conversation for today, this will come up later on in the renewal process, is that as we go down this pathway of exploring GLP-1 drug coverage, either for the 24-25 or 25-26 plan year, we can think about using the benefit structure of the GLP-1 coverage as a way to help mitigate costs as we ease our way into it. This could potentially include higher cost share amounts on the GLP-1 drug for weight loss class. It could also include an annual or lifetime benefit maximum as well. And then, of course, the cost can also be subsidized through benefit reductions on the whole plan. But to avoid those, we could target slightly higher costs on the GLP-1 or benefit maximums as well. And then, Emily, our last slide, just to recap, I think the readiness prepare approach is Mercer's recommendation, understanding that the conversation is really complex and there are a lot of considerations to balance. An alternative option would be offering coverage consistent with the label, which includes lifestyle modification and some pretty strict requirements around active participation. Are there any questions? I know you guys must have some. Enrique?
Yes, thank you. And I saw this presentation.
Oh, you put yourself back on mute accidentally.
Oh, I'm sorry. So I saw this part of the presentation earlier in this morning's meeting, but I guess for me, I understand that diabetes and obesity can be in a genetic, illness, and also economics is a factor for individuals. But I feel that the cost, as Tom said, this is very expensive. And a small group of, based on the numbers, will benefit from or will have access to this medical drug. And I feel if we continue to say yes to this high cost medical procedures or drugs, I don't feel we have any leverage with the manufacturer, right? The research, the manufacturing infrastructure spend there's been paid for. So when people say, it's the research and the cost of medicine development, I don't believe it. And Sarah pointed out that pharmacies and these groups spend a lot of money on marketing. So I think we're paying for marketing Vince's health. So I just convinced me, how can we lower that price, or can we go back to the table to those manufacturer, pharmacist, or company, hey, this is too much for us. That many states are offering this drug on our plans. And I feel we can bargain with them. I feel that we can sit here and be like, only 3 states have this. Other 2 states have pulled away from the market. So I think we have the upper hand on negotiating. So I just my thought. I think it's just a lot of money. I'm not saying I'm against it, but I think we should sit down and at least try to reduce the cost with the manufacturer.
I appreciate that perspective, Enrique. Bill?
For me, I look at this more, and it's not, at some percentage that's not here is in the longer term, if we can get some small percentage or hopefully a larger percentage of people to get accustomed to a lower weight and actually wish to stay there, we're going to reduce costs in related diseases, and especially cardio diseases and things like that for our membership. That's the theory anyways. And that's what gets promoted in the medical journals as well, that this is a portion. Now, not everyone's going to stay, at the ideal weight, but in any portion of that that's significant enough to cover is a help.
Thanks, Bill. Sue?
To Bill's point, and I'm sorry if I missed it in the presentation, but has there been any modeling relative to the cost benefit if we, even though this is significantly expensive therapy, the associated costs, if not done, and patients shift right and experience the cardiomyopathies, the renal failure, and other conditions that are associated with type 2 diabetes. So that might give more reason to consider this particular therapy.
Yeah, I appreciate that, Sue. It's something that we've talked a lot about in particular. We know theoretically and philosophically that we're improving health outcomes to some degree at some point for some people. Potentially, some people are going to have significant health outcomes, and absolutely there would be savings for those people in the long run. We have not attempted to put together a long-term financial model, be maybe a 5 to 10 year view that tries to take that into account. I think the financials in this presentation that we've been discussing so far are focused on a more operational aspect, which is, unfortunately, Senate Bill 1067 doesn't allow us to take a multi-year, long-term in the future view and acknowledge potential clinical savings down the road in a short-term investment. We really just look year to year for whether we've met that test. So the cost modeling in this presentation is relatively short-term as well. I like what you're suggesting, though. We have to think a little bit more about that, but I just want to acknowledge the validity of what you're saying.
Thank you.
The problem, I was just going to comment that the concern is that the studies have all been driven by the drug companies, and their interest is to get that FDA approval. It's not done from a public health standpoint, because if it was a public health standpoint, what you would do is you'd identify a population, you'd run the medical health economics ahead of time of how much you're paying for joint replacements and heart disease and all those things that you mentioned, Sue, and you apply the intervention over a large enough of a population and then follow it over a 10 or a 5 to 10 year period of time to see what would happen. That's if you really were concerned about the impact of this type of treatment for the health of a population, and that's not how. Sadly, it's not how we're organized in regards to this issue. The only place that you really see that has been in the collaboratives around cancer treatments, where you have protocols and collaboration and you build networks of 100 facilities and they collect all their data and stuff like that. But sadly, for this one, we don't have the data that we really need to be able to figure it out.
I appreciate that, Tom. My reason also for asking is that I have received communication from a number of the legislators that represent my area here in Tigard, Tualatin, and they are very much pro these medications, and so they have intense interest relative to OEB stance, and
they're leading the charge in the legislature to change the 3.4%, right?
Yeah, yes. And so I appreciate your perspective.
No, they aren't, because they haven't. No one has said a word about it.
No, I hear that, and that's certainly the next question. But I
Yeah.
appreciate that perspective, Tom, because that helps me then on our end, and this may be something that Glenn can also help us with, is when we have those individual conversations with our legislators, is to help frame what it is that OEB is charged to do, and unless you change that 3.4%, here's where we stand. So thank you, I appreciate that.
Yeah. Enrique, you have your hand up.
Yeah, I was wondering, can we go back in to the manufacturer and be like, hey, we're interested on this, but can you lower the cost?
Yeah.
Can we do that?
This is so global. We are, this is a $15 billion. The combination of Wegovy and Ozempic is a $15 billion proposition for Novo Nordisk, the company that makes these. It's we're the minnow in the ocean of you can say sharks or whatever.
So we're little fish.
Whatever big fish you want. We are, even with our numbers, we're a little fish, and there isn't what you're describing. Doesn't exist that I know of.
Well, I'll try.
Yeah, no, you did. That's a rational, reasonable thought of when things seem, outrageous. What do you do about it? And it's okay. We are at 3:32.
Hey, Tom, Ali has his hand up.
Ali has his
also.
Oh yeah, I'm sorry. I was going to say we have 3 more minutes, so let the questions continue. Ali.
Oh, thank you so much. To Enrique's point, just wanted to mention in the Health Authority, the Health Evidence Review Commission is starting to conduct public hearings on coverage, with the Medicaid population, PEB and OEB. I think Tom mentioned earlier, that's about 1 in 3 Oregonians. But I actually was wondering, I heard the FinFin situation from the 90s earlier today, and are there safeguards in place now that would prevent, something like this happening again, where down the road, there's long-term health effects from some of these interventions?
I'll jump in, and Sarah can say if I've got it. The advantage is that these drugs have been, as she talked about earlier, have been around now for a while. They've been used, for years with diabetes, and it's only recently that that they're being used for specifically for obesity and weight loss associated with that, and there always is. There's always an issue with relatively new treatment, but usually when something is used in this number, the data starts coming out relatively. Would have come out by this time.
Okay, thanks,
Tom. Sarah, did I get that right? Or are you still on?
Oh, sorry, you're on mute.
Here we go. Yeah, you got that right. I would say while the drugs have been used for diabetes and we've got probably 20 years of data on the use of the drugs in diabetes. The length of time that we have for the use of the drugs in people that don't have diabetes is a lot shorter. And the number of people that the drugs have been used in is still relatively small. So I think there's still potential that we could see the emergence of some more serious side effects over time as the use of the drugs explodes in terms of the number of people using them. And that's something that is going to continue to need to be monitored both through the FDA and at the provider level. I can't say it's not a risk.
These are also, though, difficult drugs to take. I mean, they do have a significant side effect profile where a quarter to a third stop the medication because of side effects that are not tolerated. At least that's what I've heard. Is that fair, Sarah?
Yeah, I mean, between the injection itself, which is of course not fun, and then there are a lot of rather unpleasant side effects, right? The drug works by making your stomach empty more slowly. So you have side effects like that can be a slowed GI system. And we've heard about GI system paralysis even coming out in a small subset of people that are taking the drug. So yeah, absolutely.
Okay. We now are a minute over, but good questions. And as I say, at CIAO, we spent over 2 hours going through this conversation. Just to wrap, we've folded in a lot of the public comment already. The only additional one that, including the individual testimonials of people who wrote us, the OMA, I would like to address the note that we received from 3 representatives. In their comment, they said they were hoping that OEB and PEB eliminate the exclusionary language, and then said it did not actually force the hand. It just gave then options. One of the things that we're asking our staff and consultants to look at is actually, if we eliminate the exclusionary language, are we then actually required to offer the medication for weight loss? Because I think what's holding back the barn door now is the fact that OEB has exclusionary language for weight management drugs in its, I think. So that was one of the issues that raised at CIAO, and we will explore that and include that in our further conversations. If there are no other comments, I think we'll move on to the next agenda item. Kirsten, thank you for your comments and for your teams, as usual, brilliant presentation of an extremely complex. And I'd like to also just acknowledge the work that this is really 9 months worth of work that started in the summer with participation from the plans, including Providence, because we were looking at this from a combined OEB and PEB standpoint, and the OHA staff along with Mercer. So thank you all of you for really wrestling a complex issue. Okay, next is the director's report. Ali.
Yeah, thanks, Tom. Earlier I mentioned the 3 new board members coming in February to fill out the remaining vacancies on the board, which is obviously very exciting. And we also have exciting news in that an OHA director has been hired. It starts on January 17th, and her name is Dr. Sejal Hatti. And as you may have seen from the announcement that I recently sent to you all, she has a really impressive background. She's a board certified attending physician who treated patients during the pandemic, during the really toughest days of the pandemic. She served as a public health policy advisor in the White House And she actually currently serves as a deputy public health commissioner at the New Jersey Public Department of Health. So she's moving back out. She has family on the West Coast and is looking to get back out west. Dr. Hattie was here last week. She to get to know members of the OHA leadership team and get situated in Oregon. She said she was really drawn to Oregon by our state's commitment to health equity and national leadership in healthcare transformation initiatives. And also, she really saw Oregon as being probably the most innovative state. So her first order of business will be filling out her leadership team, which is currently comprised of several folks in interim roles. So I was really happy to hear that. We're really excited to work with Dr. Hattie and are looking forward to her start date. I'm hoping to schedule some time for a meet and greet with the board here in the near future and to talk about her short and long-term goals for the Health Authority. Other than that, I just wanted to say happy holidays and thank you for your many hours of volunteer time to make this board successful and really deliver results to OEB members. I can't express enough thanks from the staff. So Tom, back to you.
Thank you, Ali. I had, under board chair business, I have two issues. Just to say, in January, we'll be bringing you the open enrollment data. There's just a little bit more analysis that's going on there. And earlier, you heard that we're in regards to the RFP for the EAP program. We have 3 people who have stepped forward, Bonnie, Bill, and myself. That's 3. It would be great if we got another 1 or 2 board members to join us. So please think about that. And if you have any interest, the good news is that if you saw the timeline, it will be relatively compact. It will get through it in, I think, in about 2 months or so. It will not be, I don't think it will be hundreds of hours. It will maybe be tens of hours, but that can be, if you have any interest, talk with Ali or Damien about this. And that, Ali, that will start like in January, you think?
Yes, that's my understanding. Brian, Damien, speak up if that's wrong.
A second to open up the timeline. I'll speak up in just a second.
Okay.
Okay.
No worries.
So, Brian, were you going to? I didn't understand what you said.
He was just going to verify on the date.
Fine.
Yeah.
Perfect. Thank you
I'm
very
almost
much.
there.
Okay. Yeah. No. You take your time. I've got a couple more things to do. Is there any additional business for the board? And in terms of public comment, this has been the most active public comment period I've had into my 8th year on the board. And as I say, instead of taking it as a separate component, what we did is we've tried to weave it into both our conversations this morning in CIAO and afternoon presentation. Rose, is there any additional public comment, both live or written, that we need to know about?
Not that I know of. Someone was going to make public
Okay.
comment, but I think she decided against it. Allison, are you on? No, I think she decided to just give her written comment. So I don't have anything else.
Okay, thank you. And
Tom, just to follow up,
just for the board. Yeah.
The current RFP schedule has our evaluation taking place the first 2 weeks in, I believe it's January. Let me double check that really quick. excuse me, February. So the first 2 weeks in February will be when we'll have board
February.
members and staff review portions of proposals and score. And then assuming that we end up wanting to have finalist interviews, those are scheduled to take place the week of March 18th. And your comment's correct. The lift for evaluators will be nowhere near a medical or even a dental RFP. It'll be much more focused for both staff and for board members participating.
Great.
Thanks, Brian.
Great. Thank you very much. Okay. So don't be scared by this one. There's, again, we love the comments. So with that, I think we are adjourned.
Thank you.
Bye all. Thank you all for your participation.
Bye-bye.
Goodbye.